the next thing we'll speak about here is the pulmonary function tests and how we can use these volumes. And again, not just the amount of air, but how much time it takes to move that air in and out. And so based upon that information, we can class lung diseases into two large categories: obstructive lung diseases and restrictive lung diseases, or restrictive pulmonary diseases. And so obstructive pulmonary diseases are usually problems with the airway. Okay, we talked about COPD as a main example, emphysema is another example, asthma is another example, but essentially there's some obstruction happening in the airway of the lung. There's increased resistance there, things like that mucus production, the bronchoconstriction that happens as a part of the inflammatory response. And so that type of increased resistance makes it really hard for air to come in as well as out. More importantly, for air to come out, right? And so what we typically see is overinflated lungs. I talked about that barrel-chested, nature that we see most COPD patients with, because after a while of breathing air in and not being able to get it out, we end up sort of overinflating, hyperinflating the lungs. And so that typically expands the thoracic cavity, usually in more chronic instances such as COPD, and not so much with asthma, okay? We also see the functional residual capacity increase. And remember, functional residual capacity, based upon what we just drew, is our expiratory reserve, so the amount of air we can force out, along with our residual volume. And another way to think of functional residual capacity is the amount of air that remains within the lungs after a quiet breath, okay? And so when these patients are, typically breathing normally, their functional residual capacity starts to increase because they're having a hard time getting that air out. And so residual volume increases, expiratory reserve increases, and so that total capacity will increase as well. Now, vital capacity is going to decrease on the other hand, and that's because, remember, vital capacity is the amount of movable air. It's tidal volume, it's inspiratory reserve, along with expiratory reserve. And so as more air gets left behind in the lung with respiration, the amount of air that's moving decreases naturally, okay? So obstructive lung diseases, a problem with the airway, right? The movement of air into the lungs. And so we see an increase in the amount of air that's left behind, so increased functional residual capacity, and a decrease in the amount of air that's actively moving, or a decrease in our vital capacity. Now, restrictive pulmonary diseases, on the other hand, this is an innate problem with the lung itself, the lung parenchyma, the lung tissue, the alveoli. And so because of that, there's decreased compliance, and it's really hard for the lungs to expand to accommodate any type of inflation or air coming in. As a result, all of the lung volumes decrease. The total lung capacity decreases, and we know that total lung capacity is a reflection of all of our combined lung volumes, okay? The vital capacity also decreases. Again, all of the lung volumes decrease because we just cannot get air in. The lungs are not functioning the way that they should because of that decreased compliance, that decreased ability to inflate and to accommodate the expansion of the alveoli and the opening up of the lungs. Okay, examples of restrictive pulmonary diseases are usually things like tumors of the lungs, so pulmonary carcinomas, also a whole class of diseases called pneumoconioses. And it's a really fancy word that you don't have to remember, but I'm sure you've heard of the word mesothelioma, right? It's usually in commercials, usually having to do with workers' compensation. And so it's an exposure to asbestos, and that can really cripple the lungs' compliance. And so that's what we see, this restrictive kind of fibrotic nature of the lungs that makes it really hard for the lungs to expand. And there are many other environmental exposures, usually working in different factories, if there's silica in the factory, lots of different exposures that can create different types of pneumoconioses. But mesothelioma is, I think, one of the more common ones. Okay, so inherent destruction of the lung tissue of the lung parenchyma with a tumor or a cancer or some type of environmental exposure. All right. And so when we talk about these pulmonary function tests further, we can think about forced vital capacity. This is the maximum volume that we can inhale and then quickly exhale. So again, thinking about the timing of how we can move that air in and out is a really important part of thinking about how well the lungs are functioning, right? That pulmonary function. And so a low forced vital capacity is indicative of a restrictive pulmonary disease. And so that's really because the lungs, again, they cannot expand, they cannot inflate. And so this decreases all of our lung volumes and by extension decreases our forced vital capacity. When we think about the other important pulmonary function test here, the forced expiratory volume in 1 second, or FEV1, this is the percentage of our forced vital capacity that we can exhale in a specific time frame, so 1 second specifically. And again, you think about inhaling the maximum air that you can in, exhaling as much of that as you can out, and so that's going to be a measurement of how much of your total forced vital capacity can you exhale in 1 second. Now, typically in you or I that have healthy, normal lungs, that'll be 80%. So we can expire or exhale 80% of our forced vital capacity in 1 second. And if we think about the actual volumes here, if our forced vital capacity is about 4,000 milliliters, we should be able to quickly expire about 3,200 milliliters of that in 1 second. So 80% of that total forced vital capacity. In patients with pulmonary obstructive diseases, the FEV1 is drastically reduced. So it's less than 80%. In some texts, it'll tell you less than 70%. So it's really drastically reduced. And that's because these patients have a hard time moving air in and out. And so they can eventually get there. We'll talk about this on the graph here in a minute. They will eventually be able to move these volumes in and out, but it just takes so much time and so much effort because of the obstructive nature of these diseases, because there's that mucus congestion, there's the inflammation causing the bronchoconstriction. And so there's just so much impedance to the flow, right? And increased resistance that the airflow takes time. And so the amount of air that they can expire in 1 second drastically reduces. Okay. And so comparing our two curves here on the left, in A here, the first curve at the top, we're looking at a normal individual. They should be able to expire 80% of their total forced vital capacity in that first second of expiration. Okay. And we can see that reflected with this really nice steep slope to the curve, and then a flattening off as the remainder, right, about 20% of that FVC is then expired. If we think about some of our diseases here, so again, comparing that normal curve, which has a nice slope at the beginning, right, indicating that most of that air is expired in that first second, and we compare that to obstructive and restrictive diseases. In restrictive diseases, we'll see that the curve never actually gets up here. We never actually expire the full amount because we don't have it, right? It's not in the lungs. And so we have an issue with volume in these restrictive diseases. In obstructive diseases, the issue is with the time. And so in the first second, they haven't expired 80% of their FVC, but they eventually do get to that full amount of air being expired. It just takes more time. And so there's more of a gradual or more of a less steep curve, if you will, which indicates that this process just takes more time. Okay, so just to say that again here in a different way, in our obstructive lung diseases, because the issue is with the airflow and essentially the amount of time it takes to move air in and out because of all the obstruction, these patients can reach their full forced vital capacity. They can get to that 4 liters of volume, but the curve here is not as steep because that takes more time. There's more impedance or more obstruction to that flow. Whereas restrictive patients, their curve is just as steep at the beginning here. They don't have any obstruction in terms of the airway. And so their curve is going to start off nice and steep, just like our typical normal curve here, but they will never achieve the full 4 liters of volume in terms of that full forced vital capacity because they don't have that amount of air in their lungs because, again, the problem with restrictive diseases is the inability to expand the lungs, and so they have an overall decrease in all of their lung volumes. And obviously, if you don't have that amount of air that you've been able to breathe in, you obviously cannot breathe that amount or quantity of volume out. Okay. So that's our FVC, and then our FEV1, which is the percentage of our FVC that we can breathe out or exhale in 1 second. Okay, another representation of the difference between these two diseases is our peak expiratory flow rate, PEFR. This is the maximum rate that we can expire or exhale. In men, it's normally about 9 liters per second. In women, again, it's slightly less just because of different lung sizes, different muscle sizes. So the muscles are smaller in women typically. And so we have less of that ability to forcefully expire the way that men do. So they have about 9 liters per second, and they have about 7, women have about 7 liters per second. And so looking at our curve here, again, flow, which is the rate here, the amount of volume with time. So this is a rate. And then volume here at the bottom. And looking at our normal curve, we can achieve or reach our peak expiratory flow rate, again, in under 1, really quickly, right? So we can achieve that really quickly in terms of the rate here. Whereas in restrictive diseases, the flow rate is normal, but the volume is decreased. Again, these patients have trouble with volumes. All of their volumes are decreased. And although they can move the air in and out really quickly, they don't have a time issue or a delay. There's no obstruction. They have overall lower volumes, okay? And then obstructive diseases, again, are slower. So the peak of this curve happens later, right? It's gonna be more delayed in terms of that peak expiratory flow rate being achieved. And then they will eventually achieve the full volume, but that just takes more time, okay? So just 2 important distinctions between restrictive lung diseases where the main issue is the volume because the lungs cannot expand versus the obstructive lung diseases where the main issue is that delay, that obstruction because of that airway congestion. All right, now the final thing we'll say here in this packet is really about alveolar ventilation and minute ventilation. So minute ventilation is going to be the total volume of air that is entering and leaving the respiratory system per minute. And a simple calculation for minute ventilation is our tidal volume multiplied by our respiratory rate. So what is our breathing rate? And that is basically how much air we're breathing in per second, or per minute, excuse me. And we multiply that by our tidal volume, which is the volume of air that we're moving in and out in our quiet respiratory state. And that is our minute ventilation. Now there's a problem with minute ventilation. It does not take into account the anatomical dead space. And we spoke about the anatomical dead space as the air in our conducting zone that is not actively participating in gas exchange. It's the air that's sitting between the pharynx all the way down to the respiratory zone. And so it hasn't actively participated in gas exchange. And so we should take that air into account as we think about our ventilatory rate, right? Our rate of ventilation. And so that volume is typically about 150 milliliters. And so the alveolar ventilation, which is a more specific measurement of our rate of ventilation, does take that 150 milliliters into account. Okay, so let's just look at this illustration here, which kind of underscores that difference between the conducting zone and the respiratory zone. And so we start out with moving air, fresh air into the lungs, and then we have some old air that's already sitting there that hasn't undergone any exchange yet. Okay, and then this is our alveolus here. So when we inspire, we actually push more air in. So think about the purple part of this illustration as fresh air coming in and pushing that old air down to the bottom of our alveolus, okay? And now when it gets to the bottom, it can then actively participate in gas exchange. So this area in orange, right, this air in orange, which has been sitting in the conducting zone for quite some time, has now made its way all the way to the bottom of the alveolus, and so it can actively participate in exchange. It's going to pick up more oxygen, offload more CO2, and then as respiration changes once again, we're going to see that all of this has now actively participated in gas exchange. whereas this ear in purple has not. And so as we expire, we now push more of that air out, and then we can now create more space to bring more air in, okay? So essentially what I'm trying to say is that there's not just this movement of air in, all of it takes part in gas exchange and then all of it is moved out. No, it's more of a gradual process. So air comes in, it pushes that older air down into the bottom of the alveolus. That air can participate in gas exchange. And then with expiration, some of that old air gets pushed out, but also some of that fresh air gets pushed back out as well. So there's that mixing of the air. And so this is why we should take into account our anatomical dead space when we calculate our alveolar ventilation. All right. And so a truer reflection of our ventilatory rate is the alveolar ventilation. And so that's going to be our minute ventilation, which is our tidal volume, times our respiratory rate. So that's all the air coming in per minute. But then we're going to subtract out our dead space volume times our respiratory rate as well. So we need to take into account that this air here, right, the dead space volume, 150 mLs, times our respiratory rate, this entire volume, has not gone down into the bottom of the alveolus, right? It's sitting in the conducting zone. And so it has not partaken in gas exchange. And so we really need to subtract it from our minute ventilation in order to get a truer reflection of the amount of air that is actively participating in gas exchange per minute. Okay, and that is our alveolar ventilation. All right, any questions on that bit? Any questions? Again, I posted this video, so please be sure to check it out. It's on Brightspace. It has to do with gas exchange, which is what we're going to get into next. All right. And then we'll spend the final few minutes here just looking at a few practice questions again. All right, so I'm going to launch a poll here. All right, last few seconds. Okay. All right, so overwhelming response for B. What is the vital capacity? And B is correct. So it's going to be the tidal volume, the inspiratory, and the expiratory reserve volumes. Now, some people did select C, A, and D. And remember, the residual volume is not a part of our vital capacity. Another way to describe vital capacity is all the movable volumes, right? All the volumes that are actively moving with respiration. And remember, residual volume does not move in or out of the lungs with respiration. Okay, and then as far as A is also incorrect because it does not take into account our tidal volume, which is the resting, quiet respiration. Okay, so the answer there was B. Let's look at another question here. So one more. All right, final 10 seconds. Okay. All right, so overwhelming response for B. What are the indicators for obstructive and restrictive pulmonary diseases on a pulmonary function test? And it's going to be B. So B is correct. It's obstructive, expires volume more slowly. Remember, they have an issue with the resistance because of that airway constriction. Whereas restrictive, a lower expired volume. And again, that is true because restrictive lung diseases decrease the lung compliance. So the lungs cannot expand normally. And so all of the volumes are decreased. Alrighty. And we can just kind of reflect on that looking at our two curves here. All of the volumes are always affected, right? The restrictive curve never achieves that full 4 liters, which is also reflected here, right? The volumes are always diminished, whereas obstructive patients eventually achieve those volumes, but it just takes more time.